This program contains graphic images and discussion. Viewer discretion is advised.
Tonight's webinar, Environment, War, and Conflict, will focus on how climate-fueled catastrophic environmental events have and will continue to force mass displacement of populations within and across borders, creating increasing threats to the health of migrant and refugee populations. These threats include the direct and indirect consequences of war and conflict, such as a lack of clean air, water, nutrition, and housing, increased exposure to infectious diseases, and psychological trauma. The session will also explore how war and conflict fought over the control of fossil fuel supplies has in turn fueled our climate crisis and related social and environmental injustices. Now, I'd like to introduce you to Dr. Robert Gould, who will moderate this session. Dr. Gould is an associate adjunct professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSF, and president of the San Francisco Bay Area chapter of Physicians for Social Responsibility.
Thank you, Anne-Marie, and it's wonderful to be here, and I want to welcome everybody to tonight's session, which, as Anne-Marie has outlined, is too often not been looked at in terms of when we're looking at environmental health, issues of climate change, that our many expert speakers tonight are going to be able to address so well. So it's my distinct pleasure to open up our session tonight by introducing Dr. Barry Levy, who's adjunct professor of public health at Tufts School of Medicine and a consultant in environmental and occupational health. He has co-edited 20 books, including War and Public Health, Social Injustice in Public Health, and Climate Change in Public Health, and he just completed writing a book on the recognition and prevention of the health impacts of war entitled From Horror to Hope, which will be published later this year. He has worked in Kenya, China, Thailand, Jamaica, and Central and Eastern Europe, and he has served as president of the American Public Health Association, where it's been an absolute delight for Patrice Sutton and I to have worked with Barry for many decades. Barry, welcome.
Likewise. Thank you very much, Bob. This evening, I'm going to be talking about the many impacts of war on public health, and I'd like to share my screen here. And I have no financial disclosures. So first, I want to, in a summary fashion, talk about the major impacts of war. They include injury, disease, and premature death, mental disorders, violation of human rights, forced displacement, damage to civilian infrastructure, everything ranging from hospitals and clinics to water treatment and supply systems, contamination in the environment, and I'll say more about each of these issues as we go on, diversion of human and financial resources, and war causes even more violence. It's one thing to talk about it in somewhat abstract terms. It's, I think, more meaningful when we start talking about real people. War to a child may mean witnessing atrocities of war, may mean separation from parents and other caregivers. To a woman, war may mean gender-based violence. It may be becoming a widow at an early age. To an older person, it may mean displacement, may mean loss of medical care, it may mean no access to medications, and of course, many other problems as well. To a displaced person, it may mean loss of community, separation from family, and desperate attempts at accessing basic needs like food and water. To a military veteran, war may mean years and years of post-traumatic stress disorder and depression. To a person whose family members have been killed, may be profound, for certain, it would be a profound sense of loss for many years to follow. There are important trends to understand in terms of war in the 21st century. There are actually an increased numbers of wars. Many of them occur in far-off lands that don't make the front pages of our papers, or even the inside pages of our newspapers or our websites, news websites. Most wars today are intrastate conflicts, and most of those are civil wars, which encompass an entire country. And increasingly, those civil wars involve other countries, so they're internationalized. Much warfare today is urban warfare with extensive use of improvised explosive devices and the increased impact of those attacks on civilians. Civilians and civilian infrastructure are both indiscriminately affected during a war by various weapons, but also increasingly targeted. Almost 80 million people are displaced in the world, and you'll hear more about that later. Roughly 60% of them are displaced within their own countries, and most of the people who are displaced worldwide are displaced by war. And it's important to understand that the indirect consequences of war in terms of illness and injury and premature death occur primarily because of damage to the civilian infrastructure. Bombs and bullets and other weapons on average cause 5%, 10% of deaths in most wars today. Most of the deaths and severe illnesses are in fact due to damage to the civilian infrastructure. Militarism and military expenditures are an important part of this equation in terms of why there's so much war in the world today. The United States military budget in fiscal 2019 was over $700 billion. That's more than the next 10 countries combined: Russia, China, Germany, France, the United Kingdom, and so forth. The next 10 countries combined do not equal the US defense or military budget. And there's immense diversion of resources away from health services, education, and other social benefits to support our military. There are many causes of war. A colleague of mine says a lot of this boils down to grievances and greed, but specific causes include disputes over power or land, socioeconomic and political inequities, and of course, poverty, ethnic and religious tensions, militarism, widespread availability of weapons, and government failure to fulfill the basic needs of their populations. And there are also emerging possible risks for war, including increasing nationalism, erosion of the world order that is largely, although not entirely, but largely kept global peace since the end of World War II, climate change, which represents new risks, cyber warfare, and there's already a precedent where cyber warfare has led to physical warfare, and COVID-19, although we do not yet know whether COVID-19 will lead to, in fact, more armed conflict or less. And by the way, I'm using the terms armed conflict and war interchangeably. Civilians are affected by indiscriminate attacks by bombs, drones, cluster munitions, landmines, unexploded ordnance. I'll say more about some of these in just a moment, but also by targeted attacks. And some indiscriminate attacks in the past have occurred on a large scale, like the firebombing of many cities in Europe and in Japan during World War II. This is an aerial view of the firebombing of Osaka, Japan in 1945. And on a more personal scale, there's an indiscriminate attack on a little boy, this 10-year-old boy in a Cambodian refugee camp in Thailand. You can see he has surgical scars because he was wounded in his left shoulder and his abdomen. He survived, but his 4-year-old brother, whom he was carrying across the Thai-Cambodian border, did not survive. Landmines represent a major problem. They are still deployed in almost 60 countries. They make land unusable, and of course, they cause many injuries and deaths annually. Children and displaced people are at most risk. Victims tend to live far from medical care, so if they get affected by a landmine explosion, it's not likely that they will survive. And of course, it leads to many amputations of legs and arms. The Mine Ban Treaty, which came into effect in 1997, prohibits the production, stockpiling, and use of landmines. 164 countries, but not the United States, have signed the Mine Ban Treaty, and the United States, along with Russia, Pakistan, India, China, and some other countries, still stockpile large amounts of anti-personnel landmines. This little boy lost a leg, part of a leg, as a result of a landmine in Cambodia. At one point, 1 out of every 250 people in Cambodia was a landmine victim. And there are targeted attacks on civilians and civilian infrastructure, physical and sexual assaults, and also bombing of hospitals and clinics, agriculture and food systems, and water treatment plants and water supply systems. This is a bombing of a pediatric ward after the Gulf War in 1991. And this is a woman rushing her young child to an emergency department, only 2 that were functioning during the beginning of the US invasion of Iraq in March of 2003. There are increasingly attacks not only on healthcare facilities, but on physicians and other healthcare workers. In Iraq, for example, in 2008, a study found that 80% of physicians working in emergency hospitals had been assaulted by patients or family members. And in Aleppo, Syria, by 2015, more than 95% of the physicians had fled or had been detained or killed. There are only 36 physicians remaining. Immunization programs and other public health services are disrupted. And in many places, there's no safe water supply after a war. This picture was taken in Iraq after the Gulf War in 1991. The water treatment plants were destroyed, and women, mainly women who were traditionally gathered water from rivers that they knew to be contaminated, but it was the only water sources that were available. Better to drink contaminated water than to die of thirst. Civilians are affected by many diseases, as already stated: malnutrition, infectious diseases, mental disorders, abnormal pregnancy outcomes, and to make matters worse, inadequate medical care. This is a 7-year-old girl in a refugee camp in Thailand. She weighed 27 pounds. When I came home from working in the refugee camp, I almost didn't recognize my 1-year-old son, who weighed the same amount, 27 pounds. Malnutrition is a major problem, and so are many infectious diseases. Children who get measles or diarrheal diseases or upper respiratory tract infections are much more likely to become severely ill or to die because they are malnourished and are living in a resource poor, or have lived in a resource poor environment. Mental health disorders are common. This 12-year-old boy could no longer see. He had so-called physiological blindness after having witnessed both of his parents being killed during the Cambodian genocide. Vulnerable groups are women, children, displaced persons, members of minority groups, and indeed many others. Indigenous peoples, for example. 10% of women worldwide are displaced by war or live close to war zones, that is within about 30 miles of war zones. Gender-based violence affects many women. One survey found in one war zone, more than 20% of women had been either raped or otherwise affected by gender-based violence. There's a very good book that recently came out by Christina Lamb entitled Our Bodies, Their Battlefield. She's a British journalist who has covered many wars for a number of years, and she states in the book, which is accurate, that rape is the most neglected war crime. Women also suffer from adverse pregnancy outcomes. Many women become widows. In India, which has more war widows than any other place in any other country in the world, there's 25,000 war-made widows, many of them having become widowed before the age of 30. Children suffer, of course, as well, quite a bit. 16% of children worldwide are either displaced by war or live close to war zones. They have high death rates, mainly due to the combination of malnutrition and infectious diseases, loss of education, loss of community, mental disorders, and many, about 250,000 worldwide, have been forced to become child soldiers. There have been child soldiers in wars in 36 countries in the last 2 decades. Here's some child soldiers in Sierra Leone right before they were reintegrated back into society. And of course, that raises the issue of the importance of reintegrating these children, and of course, many other people who are displaced in various ways by war. There are almost 80 million displaced people in the world, 60% internally displaced, who are far worse off in general than refugees who cross borders and are helped by other countries, both the host governments and international agencies. Most displaced persons are women and children. They have high morbidity and mortality rates, inadequate healthcare and other services. This is a makeshift tent city for displaced people, internally displaced people in Somalia. This picture I took in a refugee camp in Thailand for Cambodian refugees. It demonstrates a couple of things in terms of environmental issues. Women cooking over an open fire like this, generating smoke, which can cause respiratory irritation. But also refugees are often forced to gather firewood, including cutting down trees, in order to cook food in refugee camps. And so they're really given no other choice, but if they want to cook food, to gather firewood and cut down trees in the process. Many of the countries that host refugees have difficulties meeting the needs of their own populations. Here are the 4 leading countries in terms of numbers of refugees that they're hosting. All of them are countries that have challenges meeting the needs of their own populations to begin with. Air pollution, water pollution, and land pollution are important issues with regard to war and the preparation for war. Military forces use fossil fuels, which contribute large amounts of greenhouse gases. Air is contaminated during battles by chemicals, by the destruction of buildings. During the Gulf War, retreating Iraqi troops set fire to 600 oil wells in Kuwait, causing a great deal of air pollution. And this development and testing of weapons, notably the open air testing, atmospheric testing of nuclear weapons from the late 1940s to about 1980, caused much radioactive fallout and wide dissemination of radioactive materials. Two large meta-analyses have demonstrated that conflict, various forms of conflict, is associated and seemingly resultant from high temperature and or extremes of precipitation, that is drought or flooding. Now, there are many conceivable mechanisms on how this might happen. Here's one that I'd like to sort of chart out with you. High temperature and drought leading to crop failure and damage to farmland, leading to food shortages, loss of income, and stress migration, that is farmers and their families being forced to move to cities where they may contribute to existing socioeconomic and political instability, and ultimately contribute to maybe not be the only cause, but to contribute to war. Now, this may seem theoretical, but this is actually what happened in Syria from 2006 when a great drought began, the worst in a century. Much farmland was turned to desert, many animals died, people were forced, about 1 million people, farming families were forced to move to cities, and that contributed to, not certainly the major factor, but a contributing factor to the start of the civil war in Syria, which has claimed almost 500,000 lives and led to 12 million people being displaced. Conventional weapons include small arms and light weapons. Primarily, these are the major weapons in most wars, most civil wars. The international arms trade continues to go on at a very high level, making arms available in many countries throughout the world. And the United States is the largest supplier of in the international arms trade. A hopeful sign is the recent adoption of the Arms Trade Treaty, which requires countries to not sell arms to those that might violate humanitarian law or support terrorism or organized crime. Another issue is armed drones or unmanned aerial vehicles, which have been used extensively by the United States to attempt to kill so-called suspected terrorist suspects in other countries, largely Pakistan, but also Afghanistan and elsewhere. Often civilians have been killed in the process. Another issue in terms of the ethics of war is the fact that the people who operate these unarmed drones, which can be used not only to fight terrorism, so to speak, but could be used in battles and wars, can be operated by people halfway around the world who aren't at risk themselves of being injured during a war. There's all kinds of ethical issues being raised by that. Weapons of mass destruction include chemical, biological, and nuclear weapons. Chemical weapons were first used in World War I. They were used by Germany in the gas chambers in the concentration camps in World War II, by Japan in the 1930s. There were 2 attacks in Japan in the 1990s. They were also used by Iraq in the Iran-Iraq War and by Saddam Hussein against Iraqi Kurds. And they've been used multiple times. Some people say as many as 300 times by the government of Bashar al-Assad in Syria against his own people. The Chemical Weapons Convention, which was formally put into effect in 1997, has been hugely successful. Although these weapons have been used recently in Syria a number of times, they have been almost completely destroyed by almost all the other holders of chemical weapons. The United States is planning to destroy its 2 remaining stocks within the next 2 years. Biological weapons have been used sporadically over the years, as shown here. The Biological Weapons Convention, although not adequately funded, arguably, has still had a profound effect on limiting the development, production, and certainly the use of biological weapons. The United States and Russia and other countries no longer have offensive biological weapons, but the United States and Russia still conduct biological weapons defense research, which still represents a problem because these agents could leak out of these laboratories, one of which is in Boston, and conceivably could cause a risk to the surrounding community. The use of nuclear weapons occurred twice at the end of World War II, as we're all aware, Hiroshima and Nagasaki. 200,000 or more people died within immediately or within the next few months, and many more due to leukemia and many cancers in the years that follow, and of course, long-term psychological effects. Over 500 tests of these weapons in open air, as I mentioned before, and underground tests since then, although many of those have ceased. Environmental contamination from radioactive fallout, increased leukemia and other blood-related cancers downwind, and testing caused the total destruction of some Pacific atolls, such as Bikini Atoll in 1946, and caused radioactive fallout to populations, including the Marshallese Islanders who lived in that area. There's remaining, of course, serious risk of nuclear war today. 9 countries hold more than 13,400 nuclear weapons, about a quarter of which could be launched in a really short period of time. The largest hydrogen bomb was 3,000 times, packed 3,000 times more explosive force than the bombs dropped in Japan. Proliferation of nuclear weapons represents a threat, so does accidental launch, and nuclear winter, even a small-scale nuclear war, so to speak, between Pakistan and India could cause a nuclear winter that could lower temperatures globally and cause widespread famine, causing hundreds of millions, if not billions, of deaths. Water pollution has occurred due to ocean dumping of chemical weapons after World War II, and since then, groundwater contamination on military bases and radioactive materials, including downstream from the Soviet and Russian nuclear weapons facility in Semipalatinsk in Russia, where the Teka River downstream has been contaminated with radioactive material. And land is contaminated with explosive remnants of war, like landmines, as well as depleted uranium used to make shells harder, and defoliant chemicals such as Agent Orange, a defoliant used by the United States extensively during the Vietnam War. More than 5 million Vietnamese people had been exposed. It contains a potent carcinogen. There's some studies from Vietnam showing increased birth defects among people who had been exposed. US military were exposed. When they developed a number of cancers and other diseases, the United States government ultimately determined that they should receive compensation for those diseases. Agent Orange destroys mangroves in Vietnam, as well as affecting the health of the people. And also our bomb has destroyed mangroves in Vietnam. The bomb craters created stagnant water ponds where mosquitoes carrying malaria have bred. Prevention of war can be approached in a number of ways, and the prevention of the health consequences of war. We can think of it with a public health framework such as primordial prevention, which addresses the root causes of war, primary prevention, which prevents disputes from escalating into war, secondary prevention, which minimizes the impacts of war, and tertiary prevention, which after war helps to restore essential services, rehabilitates and reintegrates people, such as displaced people and child soldiers, and supports programs for truth, justice, and reconciliation. And we could apply this public health model for prevention to war as well, with interventions to address people, weapons, and the conditions in which people live in attempts to minimize the likelihood of war. Strategies focused on people as shown here, such as increasing understanding and tolerance, promoting economic independence and interdependence and so forth, reducing weapons, eliminating weapons, and strengthening international treaties and trying to reduce military budgets, and strategies that deal with the conditions in which people live, such as promoting human rights, reducing poverty and socioeconomic inequities, improving education and employment opportunities, and ensuring the rule of law. I showed this before as a framework or a mechanism or pathway by which climate change can lead to war. And that's sort of the bad news. But the good news is that each of these points, as shown in green here, we can intervene to prevent a cascade of these steps moving downstream, so to speak, so that when there is high temperature and drought, we can provide TA, that is technical assistance, irrigation, and resistant seeds. If there's crop failure, food and income support can be provided to communities and so forth, ultimately, which may prevent conflict. There are important roles for physicians and medical students and other healthcare workers, medical care for the victims affected, documentation and research, education and awareness raising, and advocacy, which can be done best through organizations such as APHA, Physicians for Human Rights, and Physicians for Social Responsibility, and its international organization, the International Physicians for the Prevention of Nuclear War. So there are reasons for hope, despite all the horrors of war that I presented. Many disputes are indeed being settled peacefully. There's increasing respect and protection of human rights. Older treaties have been effective, and newer treaties bear some hope for the future. Gender-based violence and mental disorders are increasingly being recognized and addressed. There are new approaches, including epidemiological approaches and psychosocial approaches that are being implemented to help prevent conflicts or disputes becoming violent. The humanitarian assistance is becoming more systematic and evidence-based, and more people are working on building and maintaining peace. A few takeaway points from this presentation: the impacts of war are extensive. Civilians are frequently impacted in the ways that I described. The long-term impacts of war are profound, but much can be done to prevent the health impacts of war and to prevent war itself. There is reason for hope. Thank you.
Thank you, Barry. So our next speaker is Dr. Fatima Karaki. She's an associate professor at UCSF's Department of Medicine. She is also the founder and director of the Refugee and Asylum Seeker Health Initiative, or RAHI, at UCSF, which fosters academic activity, research, education, advocacy, and community awareness in refugee health. Her academic and clinical interest is in refugee and asylum seeker health, with a focus on the Syrian refugee crisis in the Middle East. She is a founding member and board member of the North American Society of Refugee Healthcare Providers, or NASRAP, and co-chair of its research committee. Welcome, Dr. Karaki.
Thank you for the introduction. I'm Fatima Karaki. I'm the director of the Refugee and Asylum Seeker Health Initiative. And I decided to talk to you all today about the global refugee health crisis, but specifically about the impact that the COVID-19 pandemic has had on refugees. So we'll split our time, about half of the time talking about the global refugee health crisis and half of the time talking about the pandemic. For those of you who have heard me speak before, you know that I always start with this picture. This is a picture of my village in Lebanon, and this is our farm. Our farm is in the Bekaa Valley, which is about an hour away from Syria. You can see that we grow grapevines, and then in the foreground, you can see that we are growing onions. And this is a picture of a Syrian refugee living on our farm. So Lebanon, at the peak of the Syrian civil war, was hosting over 1.5 million Syrian refugees in a country of just 6 million people. So we had the highest number of refugees per capita of any country in the world. And so every year when I would go back to visit, I would see how the refugees were living and also how it was affecting my country as the host country. And so I started volunteering, and that's how I got involved in this field and ultimately founded RAHI. So let's look a little bit closer at the numbers that were mentioned by our moderator at the beginning. I want to take a big picture look at this and what's happening around the world. When you talk about forced displacement, it's not just talking about refugees, but you're also talking about lots of forcibly displaced populations like asylum seekers, internally displaced people, stateless people. And these numbers are growing over time. So this is kind of a busy slide, but if you look at the top left, you see that numbers have doubled in the past decade, from around 40 million in 2010 to close to 80 million today. And the other thing that you see on the top right is that the number of internally displaced people, in other words, people who have been forced to leave home but have relocated still within their own country, that's about double the number of refugees, which are people who actually left their country. And the reason for that is that if you think about it in your own circumstance, if you were forced to leave your home, you would be more likely to relocate somewhere that's still in your country. And similarly, if you're forced to leave your country, you're most likely to relocate to a country that shares a border with your country. And so if you look at the bottom right, at the source countries of refugees and the hosting countries of refugees, you can almost draw a straight line right across, right? So you can see that, refugees going from Syria are moving into Turkey, refugees from Venezuela are moving into Colombia, etc. And what that means is that even though we get a lot of attention to refugees and asylum seekers coming to the US and Europe, the fact is that 85% of the world's forcibly displaced people are hosted in developing countries. You can see that on this map here. The 85%, so the bulk of that burden is really hosted by developing countries in the Middle East and in Africa. And even though we get a lot of media attention and you hear a lot of news stories focusing on the US and Europe, these are the countries that are really dealing with those large numbers of people. So how is the US involved? We do resettle a certain number of refugees in the United States per year, and that number is determined annually by the president. So it peaked under President Obama at 110,000. And then under President Trump, we saw the lowest numbers of refugee resettlement in the history of the Office of Refugee Resettlement, dropping to its lowest last year at 18,000. And that number is just a cap on the number that can be resettled per year. So last year, for example, that whole program of resettlement was frozen in the context of the pandemic. So we didn't even receive 18,000 refugees. We received about 11,000. If you compare that number to the global number of refugees of over 25 or 26 million, you can see that it's really just a drop in the bucket in terms of our efforts at addressing forced displacement in the world. And I'll talk a little bit more later about some of the issues that we have on the border with asylum seekers on the US-Mexico border as well. First, I want to switch gears just a little bit and talk about the COVID-19 pandemic and how it has affected refugees. So this is a picture of Kutupalong refugee camp. 600,000 Rohingya refugees that have fled from Myanmar live in this camp. It's one of the largest refugee camps in the world. And they're living there at a population density of 41,000 people per square kilometer, which is about double the sort of recommended humanitarian standard by the UN, okay? So if you think about COVID and the things that we try to do to prevent it, like social distancing, masks, hand washing, and you also think about the fact that there are really severe water shortages in a lot of refugee camps. So many refugees have less than 15 liters per person per day of water. For comparison, here in the US, we use about 333 liters per person per day. So preventative measures like social distancing and hand washing can be virtually impossible in an overcrowded refugee camp. And so early on in the pandemic, there were several models and projections that if a COVID outbreak occurred in a refugee camp, it would be absolutely catastrophic, causing hundreds of thousands of infections, thousands of hospitalizations, and many, many deaths that would collapse an already very strained health system. And yet, interestingly, so far what we've seen is just 28,000 cases of COVID among 26 million refugees. So if you look at this map of where the COVID cases are in the world, it does not at all match up to the map that I showed you just a couple of slides ago of where the refugees and internally displaced people are. And so those projections have really not been borne out, and we haven't seen a high burden of COVID in refugees. And it's really not clear why this is. There's a lot of different theories. You know, a lot of refugee camps are rural and access is very restricted. So there's a theory that it's actually more difficult for COVID to enter those camps. Many refugee camps have a much younger demographic. So in many of them, over 50% of the population is under the age of 18. And we know that younger people are less affected by COVID. There's theories that they're just not testing for COVID, but at the same time, we're also not seeing higher death rates, which we would assume we would see if we were having a lot of COVID cases in refugees. So the fact is that actually it's just still too early to tell, and the models are only as good as their underlying assumptions. So that remains to be seen over time. What we do know is that the biggest impact actually of the COVID pandemic on refugees has been on their resettlement and restrictions of their movement. Because if you remember, many countries closed their borders in the context of the pandemic. And when countries close their border to combat virus spread, they also close their borders to people who still are seeking and need protection, whether there is a virus or not. So the moratorium on resettlement from March to June of 2020 meant that refugee resettlement numbers dropped drastically worldwide, not just from here in the US, but around the world. And so there's a general feeling in this field that the pandemic has been a convenient excuse to violate refugee rights and to block people from seeking asylum, which is a basic human right. So for the next few slides, I just want to take a look at some of the largest refugee populations in the world today and see how COVID has been affecting them. So just a couple of examples to drive this point home. So Syria has the highest total number of refugees, 6.6 million. And even before the Syrian civil war started, the main cause of death in Syria was actually non-communicable or chronic diseases, things like heart disease and cancer. And the pandemic has caused massive disruption of the treatment of chronic diseases, with many health facilities closed. Refugees are unable to receive care or obtain chronic medication. So for example, a diabetic can't get insulin if their pharmacy is closed. A cancer patient can't receive their chemotherapy if their clinic is closed. And a man like this, who's right now hooked up to a dialysis machine in this picture, he needs dialysis 3 times a week to stay alive. So if due to the pandemic, his access to that treatment is restricted, it means not only that these refugees who have chronic disease are at higher risk of disability and death from their chronic diseases, but it's also a vicious cycle because people who have chronic diseases are also at a higher risk of complications and death from COVID if they catch COVID. Venezuela has experienced the most dramatic increase in displacement over the past few years, going from just 6,000 refugees in 2010 to over 3.6 million Venezuelans displaced abroad today. So this is the largest recorded refugee crisis in the history of the Americas. And not only have over 30,000 health professionals left Venezuela in recent years, so there's huge staff shortages there, but the number of health professionals dying of COVID-19 in Venezuela is the highest in South America. 1/3 of COVID deaths in Venezuela is of health professionals who caught COVID due to a lack of PPE. Many of their laboratories are closed or only open part-time, so it's difficult to even get COVID testing, let alone get treatment. South Sudan is the youngest country in the world. It got independence in 2011, and then civil war broke out in 2013 that has produced 2.3 million refugees. The pandemic has led to a worsening economic situation, loss of employment, and increases in food prices. So there's a disruption in food supply chains worsened because of the restrictions on movements of goods during the pandemic. And so there were already millions of people suffering from acute malnutrition, but an additional 1.7 million are food insecure due to the pandemic. And also a lot of organizations who, like the World Food Program, et cetera, who donate food, their efforts have been diverted to the pandemic. And so they've had to decrease rations of food as well. And then Yemen. Yemen was already the world's worst humanitarian crisis even before the pandemic. And it's only made the situation worse. A total blockade by air, land, and sea imposed by the Saudi-led coalition means that refugees cannot escape the civil war in Yemen. They can't leave. So there's 3 million internally displaced people who cannot escape Yemen. 75% of their population is in need of humanitarian assistance. And the total blockade means that food cannot get into a country that imports 90% of its food. And fuel cannot get into the country, so they can't run their wastewater treatment plants. And so this has led to a really horrific famine and the worst cholera outbreak in recorded history. So you can see these two pictures of a 5-month-old baby boy and a 7-month-old girl. Both of these children died shortly after their pictures were taken. So I'm going to bring us back home for my last couple minutes. even prior to the pandemic here at home, we were experiencing large numbers of asylum seekers coming from the Northern Triangle in Central America. And the advocacy director of Amnesty International has said, the pandemic gives the perfect excuse to do what they wanted to do since day one, which is end access to asylum at the southern border. So before the pandemic, asylum at the southern border, at the US-Mexico border, had already essentially been cut off by various policies, right? So the Trump administration imposed metering, so they put a limit on the number of asylum applications per day. They also put in place the migrant protection protocols, or remain in Mexico policy, which meant that asylum seekers had to wait for their application to be processed in Mexico rather in the US. They narrowed eligibility criteria, and they applied a transit ban, which meant that asylum seekers could not apply for asylum in the US unless they had already been rejected by another country that they had transited through. And that's all on a background of all the things that you've been hearing about in the news, with family separation, detention of unaccompanied minors, all these pictures of children in cages. And then with the pandemic, all asylum hearings were suspended, and the administration used CDC guidelines to immediately deny asylum to anyone entering the country irregularly. So it was really, really devastating for anybody seeking asylum at the border. The last thing I'm going to mention is how COVID affects newcomers in our own communities here in the United States. I work as a physician. I treat COVID patients at San Francisco General Hospital. And I will say that 15% of San Francisco is Latino or Latinx, but 40 to 50% of our COVID patients in the hospital are Latinx. And 90% of our COVID patients in the hospital do not speak English as a first language. So we know that newcomers to our country, not just refugees, but immigrants and asylum seekers, they have a lot of characteristics that put them at higher risk of both getting COVID and having more severe disease, all of these social determinants of health that I've listed here. And we see that if we look at the outbreaks that have happened, a lot of them are of essential workers in meat packing plants, et cetera. And so that's just something to really keep in mind when we're thinking about who our vulnerable populations are at home and what we can do to help. I'm just going to talk about my organization, Rahi, for a minute. I did a lot of volunteering in refugee health, and I realized that refugees were not receiving the highest quality healthcare, and it very much stemmed from a lack of data on what refugees needed in their healthcare. And so my organization, Rahi, really tries to foster research in an effort to improve the evidence base in order to improve the quality of care that refugees are receiving. And if you'd like to learn more about our work or listen to our symposium, you can visit our website, rahi.ucsf.edu. Everything that we do is volunteer-based, and we would love your support. And with that, I think I'm going to end. Thank you so much.
Thank you so much, Dr. Karaki. Our next speaker is Dr. Sarah Coates. Dr. Coates completed her dermatology residency at UCSF in 2019, and in 2020, she completed a Fogarty International Center Global Health Fellowship through the University of California Global Health Institute. She has worked extensively in Africa, including Tanzania and Uganda, and in 2020, she published The Effects of Climate Change on Human Health in Africa, a dermatologic perspective, a report from the International Society of Dermatology Climate Change Committee. She is currently a pediatric dermatology fellow at UCSF and as well a member of the board of San Francisco Bay Physicians for Social Responsibility. And welcome hearing from Sarah.
My name is Sarah Coates. I'm a pediatric dermatology fellow at UCSF and also have about 10 years of global health experience working in various parts of East Africa, including Tanzania, Kenya, and Uganda. And we're going to talk today about the effects of climate change on human health in Africa. And we'll do it with a dermatology lens because that is my specialty. So as an overview of what we're going to talk about today, we're going to go over why Africa is especially vulnerable to climate change. We'll talk about how climate change impacts human health and some of the diseases that are most specifically going to be affected by a changing climate. So why is Africa especially vulnerable to the health effects of climate change? The first might be a little bit intuitive. It's its geographic location. This is an equatorial setting with a high temperature at baseline. And we actually expect temperature rises here to be greater than they are overall for the rest of the globe. And what that means is more frequent heat waves, which have consequences both for human health and for the areas of the continent that we're able to actually inhabit. Likewise, desertification, or the process by which land becomes converted to desert, is accelerating in Africa. Over the next 30 years, about 1/4 of Africans will experience water scarcity, and certain regions will become entirely uninhabitable. And that is really challenging in settings where you're requiring to live off the land and will force migration. And related to that, Africa has a largely agrarian economy. About 30 to 40% of its GDP is tied to agriculture, but perhaps more importantly, 3/4 of its population relies on agriculture as a primary income source. And what is anticipated is that as a result of climate change, crop yields over the next 30 years may decline by about 50%. And that's because of higher temperatures, water scarcity, and extreme weather events. And having spent quite a bit of time in this region, I can say that some of the people who are the biggest believers in climate change that I've ever met are the farmers in this region who are experiencing a lot of instability in their ability to grow crops. And then finally, there's already ongoing armed conflict as a result of resource scarcity, which has led to mass displacement. And one example of that is occurring in the Sahel region, which is the name for the area just south of the Sahara Desert. This is a part of the continent that's hit regularly by droughts and floods. And as a result of impaired food security, there has been ongoing armed conflict and displacement for the last several years. As of 2019, about 24 million people in this area were therefore relying on humanitarian aid. So shifting gears a little bit into thinking about how climate change impacts the health of patients in this area, there are several things that we'll talk about today. I'll go into each of these. The first is heat waves. I mentioned these earlier. This impairs our ability to regulate temperature and is associated with morbidity as well as mortality. Poor air quality affects both the cardiopulmonary and the skin systems. Changes in temperature, humidity, and rainfall affect the burden of vector-borne diseases in different populations. Frequent extreme weather events lead to injury and displacement. And then when crops fail and people are displaced, there is in turn a rise in poverty, malnutrition, and neglected tropical diseases. So I'm a dermatologist, so I think about this from the lens of the skin. The skin has a really important role to play in regulating body temperature. And the way it does this is twofold. So the first is superficial peripheral blood vessels dilate when it's hot. And that's very effective if it's colder outside than it is inside your body. It's a very effective way to get rid of heat, but generally that's not the case in warm or hot environments. And so we have this unique human adaptation of eccrine sweating, which is the most important way to get rid of heat when it's hot outside. This is the means by which we cool down as water evaporates from our skin. And importantly, the efficiency of that process depends on how humid it is outside. The more humid it is, the harder this is. And another important trade-off of this is dehydration. If we don't consume enough water, this is not an effective process. This figure on the left shows exposure to heat waves in the elderly population worldwide. And it's important to keep in mind that overheating is a leading and often understated cause of weather-related deaths. There are lethal temperatures above which humans cannot survive for very long. At 100% humidity, that temperature is 35 degrees Celsius. And at 50% humidity, it's 47 degrees Celsius. And importantly, many parts of Africa, as well as parts of the Middle East, are approaching these thresholds. And so that is really important when it comes to which parts of the globe people are able to actually live in. Air pollution is not caused by climate change. It's caused by the same thing that causes climate change. But I think it's important to mention here because it's become a really big problem in African cities. This photo on the right is from April of 2020, taken about a month after the COVID pandemic began. And people were so disbelieving that they could actually see Mount Kenya from Nairobi that people thought this was a joke. And that's because Nairobi has experienced the greatest loss of any African city in visibility. And that's as a result of increased particulate matter generation from vehicles and energy production systems. Those are the same things, of course, that drive climate change. And it's important to keep in mind that Africa is urbanizing. Lots of people are moving into cities, and this has an important effect on people's health. It leads to COPD and asthma exacerbations. It leads to things like atopic dermatitis, which are pictured here on the left, these chronic itchy lichenified plaques. It can also increase things like acne flares and other inflammatory skin diseases. But air pollution has many important effects, and that will only become more prevalent as people are concentrated into these dense urban areas. Injury is another important thing to keep in mind. I mentioned the example of flooding as an example here. Flooding risk is expected to be highest along the coast of East Africa. And we unfortunately saw a really bad example of that in 2019 with Cyclone Idai. This was a terrible storm that hit Mozambique, Zimbabwe, and Malawi. It affected millions, it killed thousands, and a lot of people were displaced as a result of this storm. And you can see some examples of the devastation on the right. You can imagine that if you're an agrarian economy that relies on regular agriculture production, this really devastated your way of life for some time to come. During events like this, the skin can be injured, which can have both acute and chronic morbidity. Of course, acutely, any injury that happens in extreme weather events allows for a portal of entry for microorganisms, but chronically, non-healing wounds become a very big problem. And this is one of the things that we spend the most time on as dermatologists working in this part of the world, is managing chronic wounds. People who have wounds like this that are not in a setting where there's wound care capacity will often go months, if not years, with these wounds, and they never heal. They're out of the workforce. This is a really big problem for people in this part of the world. Infectious disease vulnerability is a really hot topic in climate change. I'm only going to touch on this briefly. I think it almost goes without saying that the African landscape and climate are highly favorable to the transmission of vector-borne diseases. You can see that in this map on the right of malaria cases. Africa is, of course, the world's hotspot for malaria, especially the most fatal forms. And we know that all aspects of climate affect vectors, affect their animal reservoirs, and affect human behavior. In addition to that, urbanization changes the way that we interact with vectors and animal reservoirs. It brings us into closer contact with them, and that changes the ways the diseases affect populations. We'll take one example of that is the Aedes aegypti mosquito. This is a mosquito species that thrives in the tropics, as you can see on this map. And it transmits dengue, chikungunya, Zika virus disease, and yellow fever. The capacity for this mosquito to do its thing, to transmit and serve as a vector, is actually the highest that it's ever been. And that's what you're seeing here on this figure on the right, which dates back about 70 years. The mosquito's survival is optimal at 24 Celsius, and its ability to transmit dengue peaks at around 29. And so as more parts of the world approach that temperature for more times throughout the year, there will be more transmission of these diseases. Importantly, it also loves urban habitats. It breeds in human-made containers like discarded tires or buckets. And so in Africa, the combination of temperature changes and the urbanization that I've mentioned are expected to yield a much more favorable environment for Aedes. And we see that here in this figure, which shows malaria and dengue. The one on the left is now, the figure in the middle is 2050, and the figure on the right is 2080. And what you can see here is that malaria's conditions are going to become less favorable in Africa. It's not going to be as easy to get malaria because it's going to become too hot in many parts of the continent. On the other hand, dengue and the other arboviruses that are transmitted by Aedes are going to thrive in a changing climate because transmission occurs at slightly higher temperatures. Dengue is one of the fastest, it's the fastest vector-borne disease growing worldwide. It's also one of the only diseases, both infectious and not infectious, for which mortality is on the rise. And so what's happening is more people are being exposed to the virus dengue through the mosquito, which is thriving in new settings. And unfortunately, this has a really huge toll on healthcare systems. Millions, if not billions of dollars are spent each year in places like South America and in the Indian subcontinent where this is really taking off. In Africa, we know that this is also already happening. So in Kenya, in one study, about 10 to 20% of children who were febrile were testing positive for dengue throughout the year. There have also been large epidemics of chikungunya, another virus transmitted by Aedes, on the Swahili coast, as well as in Sudan, in the setting of major flooding, which triggered outbreaks of disease. And it's important to keep in mind that our efforts which have been made to control malaria, which have been huge in the last 2 decades, are not great for controlling this new threat from Aedes, and that's because it bites during the daytime. So bed nets aren't that helpful. It breeds in different settings. And importantly, there are no specific treatments for the viruses that this mosquito transmits. I want to move on to food insecurity. Crop decline as a result of desertification, which we talked about earlier, is going to affect multiple regions. I mentioned the Sahel earlier. the desert of Namibia, and then the Horn of Africa, which includes Ethiopia, Eritrea, and Somalia. The Horn of Africa is actually drying faster than at any time in the last 2 millennia. It's pictured here on the right. You can see that this landscape is already quite desertified. That's only going to become increasingly true. From a dermatology perspective, these are some of the things that we see in the setting of micronutrient deficiency. So this is a baby with zinc deficiency. They get these classic eroded plaques around the mouth and around the anus. This is an example of niacin deficiency, which I've seen quite a few times actually in Uganda in patients who are on maize-based diets. They classically get these red shiny plaques distributed in places where the sun shines, which we call photo-distributed. And they become hyperpigmented and quite debilitating. And then another example is kwashiorkor. This is diffuse protein deficiency, where babies often present with an enlarged belly, like a patient with cirrhosis. This is a flaky paint dermatosis from kwashiorkor. It can also lead to chronic pigment changes, both hypo and hyperpigmentation in affected populations. And then finally, I want to talk about the health consequences of mass displacement, which is part of the big topic for today. So as a result of all of the forces that we've been talking about, we expect there to be mass migration throughout the continent and then to other continents. This, as we know from experience, disrupts healthcare services. It disrupts disease vectors in their reservoirs, and it hampers things like vaccination campaigns, just basic public health services. In addition to that, when you have refugee camp inhabitation and overcrowding, there are several diseases that are more easily transmitted, which we'll talk about a couple of them today. Those include ectoparasites, TB, HIV, skin infections, diarrheal disease, and vaccine-preventable illness. One example is cutaneous leishmaniasis. This is a neglected tropical disease that's transmitted by the sandfly, which you can see here on the right. And classically, it presents with these non-healing ulcers that can evolve into stigmatizing scars. In Africa, leishmaniasis is on the rise. Its highest incidence is in Northern and Eastern Africa, but we're seeing it, for example, in Ethiopia in places that were not previously known to be endemic. And that's thought to be due to a combination of things, the spread of this reservoir and vector to new areas because of climate variables, and also changes in the way that we use the land. I want to give you an example of this fertile valley, where if you have a disease that is transmitted from human to vector and to human again, where there's no animal reservoir, you can imagine that in a sparsely populated fertile valley, this doesn't have a chance to take off. But if you transpose that onto this situation, a refugee camp in eastern Ethiopia, you can start to see why we have reports that in areas of conflict, for example, in Syria, there's been a recrudescence of old world cutaneous leishmaniasis. And so the concept here is, as we displace populations, we get more incidence of certain vector-borne diseases because humans are coming more into contact with them. These are all examples of scabies. There's a myriad manifestations of scabies. This is a mite infestation that is a neglected tropical disease. It affects millions of people worldwide, and it's spread through intimate contact. And importantly, people can get themselves strep or staph infections from scratching intensely as a result of an infestation. You can imagine that, again, in a setting like this, there are many reports of scabies. So migrants' latest health challenge in many instances is scabies. Reports of scabies outbreaks in refugee camps, and then even reports of trying to do things like mass drug administration to control this infestation in people who are seeking asylum because it's such a heavy burden. And then finally, body lice. So body lice live in the clothing. They are commonly seen in people who inhabit refugee camps and have no access to hygiene. And they transmit, importantly, some really significant diseases, including trench fever, louse-borne relapsing fever, and epidemic typhus. And what we've seen is that some of these diseases, including louse-borne relapsing fever, are endemic to the Horn of Africa and are being seen in refugees in places like Europe who are in new destination countries, and perhaps coming into contact with healthcare professionals who have not learned to recognize these diseases. This is a really important thing to keep in mind if we're going to care for these patients well. So in summary, Africa is expected to bear the brunt of climate change. That's because temperatures will rise disproportionately there, because of desertification, because of infectious disease vulnerability. Climate change will infect all types of diseases in this population. And we need to think about the effects of malnutrition and neglected tropical diseases in people who are migrating to new places as a result of climate change.
I want to thank Dr. Coates for her terrific presentation, and we'll move on to our last speaker tonight before we go into broad panelist Q&A. I want to welcome Dr. Rohini Har, who's an emergency physician with great expertise in health and human rights, focused on the protection of human rights in times of complex humanitarian conflict and crisis. She is a research fellow at the Human Rights Center at UC Berkeley's School of Law and works clinically at Kaiser Medical Center in Oakland, California. Dr. Har's research interests include studying the impact of human rights violations such as torture, violations of free speech and assembly, and war crimes on health. Dr. Har also serves on the board of San Francisco Bay Physicians for Social Responsibility, and I want to welcome Rohini.
Thank you, Dr. Gould. I'm glad Sarah talked a lot about the clinical aspects. I'm going to pan out and hopefully come full circle to Dr. Levy's talk. So as Dr. Gould mentioned, my work is mostly at the sort of the nexus of human rights, conflict, and health. And so I wanted to think about the presentation today from the sense of what are the lessons from the human rights and humanitarian experience for climate advocates, who I see as all of us, myself included. So maybe some good, the bad, and lots of unfinished business. And I'll try to keep myself short. I know we're short on time today. So there's a lot of reasons why I think it's relevant to talk about the humanitarian advocacy and human rights advocacy for the climate, for climate progress. Here's just a few. There's a similarity in the urgency and the moral imperative. Both kind of advocate for the government itself to act or not act, so that target is the same. The ground is always shifting for human rights. It depends on, who's in control. Same thing for climate change. Both issues, both the human rights advocacy world and climate, are cross disciplines. It matters for social work, it matters for health, it matters for politics. And among both groups, and I think this is part of kind of baked into the work, is that there's a real focus on vulnerable groups and justice. These problems are universal. It doesn't matter where you are. And for both, I feel strongly that the consequences of failure are dire. So I'm just going to speak about 4 lessons, and I'm happy to take questions about this before. This is the first time I've given this presentation, so there's probably a lot of holes here, and I'm just sort of working out a lot of this framework in my head. So if there are holes, please let me know later. So the lesson 1, I would say, is clear goals. Human rights advocacy starts around and is focused frequently on the Universal Declaration of Human Rights, and humanitarian work is primarily focused around the Geneva Conventions or the laws of war. Those were written back in 1864, and while there's been multiple iterations of them, they're still really, really strong in something we can hold our stakeholders accountable to. For the Universal Declaration, that was in 1948, as you know, and it's not a law, it's a declaration, but it's so clear and simple and easy to read. Here's Article 1. All human beings are born free and equal in dignity and rights. They are endowed with reason and conscience and should act towards one another in the spirit of brotherhood. And beyond the Universal Declaration of Human Rights, there's covenants on civil and political rights and economic, social, and cultural rights. And these are adopted by the UN General Assembly, signed into various governments' laws, and then ratified. And when they do become law, and they're something that we really can use for advocacy. We hold our recommendations to those. We hold our politicians accountable to those. And there's obviously many, many other human rights instruments as well. So I would say that in that context, I would love to see for there to be a very, very clear climate change declaration or something as easy to read. Now, I know there are a lot out there, but it hasn't had the level of progress, the level of attention, or maybe the level of common knowledge as the Universal Declaration of Human Rights. And I think that would be a big step. Another thing I'd like to ask you all is, this is a lesson on what not to do. So human rights are framed around the state and its obligations to citizens, right? You have the right to education and nutrition and jobs. Who is supposed to give that? The government. You have the right not to be tortured, not to be killed. You have the right to speak freely. Those are negative rights, but they're still, the government is obligated not to torture you, kill you, or to block you from speaking freely. But there's weaknesses baked into that framework. And I'll just give you a minute to think about what that is. So I would like to thank Hannah Arendt for this framing in her seminal work, The Origins of Totalitarianism, and Susan Zesch, my mentor and professor who taught this to me, and something I still think about years later. So lesson 2 is that the framework matters. These are the weaknesses. One is when you talk about the framework in terms of the state owing or the state being obligated, that model prioritizes state sovereignty. And so when the nation state, when that country doesn't comply, there's really no accountability mechanisms that work. We saw that very clearly even 3 or 4 months ago when President Trump was in control. We see that all over the world, that when specific states don't want to prioritize human rights or prioritize climate work, then there's really no way to get past that. Now, I know one of the questions was about the ICC. So we have these really good sort of options right now. We have the Rome Statute, which founds the ICC, their International Criminal Court. And that has very clear laws in terms of genocide, crimes against humanity, and crimes of war. But again, states have to be party to that. And even when states are party to the ICC prosecutes individuals and not governments. And so there's an inherent weakness in how far you can go there. The International Court of Justice is another human rights accountability mechanism. Again, that depends on who's willing to comply with that mechanism. That does prosecute states, countries, and not individuals, and really hasn't been used enough, but perhaps in the future. And then, of course, we can see that there's this idea of universal jurisdiction for these crimes against humanity. So just last week, the German courts convicted a Syrian ex-army soldier of crimes. But again, those are pretty weak in that they're convicting individuals. Now, in practice, this doesn't work. These are our very much not friends, President Assad and Putin. And when they want to act together, when they bomb their own citizens, then there's really nothing we can do in the human rights world. In the same way, we have our Kyoto Agreement, our Paris Agreement, the Sustainable Development Goals, and those are really all framed around holding governments accountable. I don't have an answer here, but I think there's an inherent weakness in how that is. The human rights world focuses, because it can't focus on like hard accountability, on naming and shaming. And that works to some degree, but if you have no shame, it's not going to work at all. The second point, and I think this is highly relevant to the climate movement as well, is that because we're focused on the state, we miss the stateless. And I don't mean just refugees, though I think Fatima spoke eloquently about how important it is to think about refugees, but this is why we do, because when you're making demands on the state, we're missing not just the refugees, but people who are disenfranchised, people in conflict affected populations where this isn't a priority, or fragile states or post-conflict states, or even within those groups, or within countries, oppressed or repressed groups, other vulnerable groups. And so when we're focusing our climate advocacy on state obligations, we're going to miss this entire group of people. From my work in Syria, I can tell you that even within a conflict, the human rights of those folks who are in the opposition-controlled areas just not accounted for. And then, of course, refugees. This is in Lesbos, and this is on the Bangladesh-Myanmar border. Totally not accounted for. The third lesson I wanted to mention is that within the human rights world, there's complex interactions. There's complex interactions between human rights and their health impacts, human rights violations and their health impacts, and all different things. And so the real work of that is in clear messaging and in making sure those recommendations are powerful. This picture, something about fast food and junk food, is just to remind me of how complex that is. So in practice, what do we do in the human rights world? We obsess about the recommendations and what we're trying to say. And I would say the lesson there is that we have developed a multidisciplinary group. So communications experts, legislation experts, litigation experts, advocates, community participants, and researchers have to all kind of work together to get to that progress. And I think that would be a powerful lesson as well for advocacy. And then lesson 4, finally, is that there is not just room, but a need for everyone. I will say that the best human rights work that I see is both interdisciplinary, so including all of these different groups, as well as, lawyers, health workers, doctors, public health experts, researchers, visual investigation experts, journalists, and also intersectional in that it accounts for all of these different groups and all of the different vulnerabilities. I'll give you a quick example today. This is a report that came out today about violence against healthcare during a pandemic, but it was organized by a nonprofit group, Insecurity Insight, an academic group at Berkeley, the Human Rights Center. We involved doctors, we involved journalists, we involved all kinds of health workers that we interviewed. And on top of that, none of that even can really get published unless the Associated Press picks it up. And you can look at that. I would say that I really think about, the weaknesses and the strengths of the human rights movement. And I think there's a lot of lessons to learn. I have kept it quite short today. But again, that benchmarks and laws are really useful, and declarations, while they seem idealistic, can really clarify the goal. That there's these inherent fragilities in focusing on the nation state, and I don't know how to get past that, but that's kind of what I'm stuck on. That we need to accept the complexities and how complex the interactions are, which Dr. Levy spoke about beautifully, and really sort of filter in a very clear message at the end. And we really need to include many, many, many voices. I'll stop there. Thank you.
Thank you so much, Rohini, for your concluding session here, which certainly opens up a lot of questions for all of us on the panel in terms of what do we do about these problems that for many of those working in the environmental health space have sort of been offshore. They've been siloed off from our concerns. In terms of questions that have come up, perhaps open this up to any of you, because a lot of what we've been focusing on here are the rights of humans, human rights and the relationships of all these problems caused by war, conflict over resources, whatever. Elizabeth, Milos in the Q&A was raising an interesting question about and whether it helps us solve the problem, as to the fact that Bolivia has enshrined in its own constitution rights of nature. So that we extend the framework beyond, certainly without any diminution of the import of all the other issues we've been focusing on here in terms of human health and human experience. But does anybody have a comment on thinking about the web of life within which all of this is embedded and all that is threatened as well by warfare? Any reflections on Bolivia's constitutional embrace of this concept?
I don't know much about Bolivia's rights of nature, but I do think it's really provocative and interesting to like move beyond the rights of humans. And I'd love to learn more about that, because I think I didn't say this in the presentation, but when we talk about all the people whose voices are not heard, certainly like Mother Earth is not heard there either. And like that voice is missing in that.
Anybody else perhaps want to respond to that? Otherwise, another question that Elizabeth raised in the Q&A, and I would welcome other people to also contribute for the time that we have remaining, were issues of dealing with privatization. For example, privatization of water in Chile, and this is obviously a common experience throughout the global capitalist system in terms of the challenges that are brought to people's lives that are more and more stressed out by global warming. So I'd be interested if any of the panelists have a response to that. And I would append, just to seed some discussion as well, since we're all gathered here in a space that we're normally talking about the normal climate health range of issues, what people think are the particular challenges we would have here in our own nation, particularly in a country that on the one hand is doing a lot of good things to reverse what went on in our prior administration in terms of climate and other environmental health issues, but at the same time has not yet necessarily given up the traditional approach that our country has had in terms of the warfare state, the arms sales, and still not even criticizing very obvious human rights abuses if we're thinking about the most recent revelations about Khashoggi in Saudi Arabia. So why don't I open it up to any of the panelists to respond to any of that?
I'm, impressed once again on how all these issues relate to one another. I mean, there are any, dividing lines that that government or academia or other, entities place on these, putting things into separate silos are of course artificial and really inhibits our mutual support of one another. And these issues, I mean, not only they cross national borders, but they cross disciplines. And obviously we need to all be working together in a number of ways. The other thing that strikes me is that, obviously no one administration in Washington is going to, I mean, even if it weren't for the last 4 years, is going to, be able to deal with all these things. It's going to take people working at every level, including at the local level, and seeing what we can do in our own backyards, and for example, refugees who are here in this country, and how we can develop partnerships with people around the globe. I think that the fact that we're all on this panel together by Zoom reminds us that there are some opportunities now that may not even been available a year ago in terms of communicating with people and building solidarity and assisting existing movements and creating some new movements, as Rohini, for example, suggested. And so I think there's a time of incredible opportunity, but we shouldn't only be focused on the Biden administration, for example, but think more broadly in terms of the many opportunities that are present. And I guess one other thing, and it's so easy to get overwhelmed, and that's why I put the last couple of slides in my presentation to to, to think about not only the major challenges we face, but the reasons for hope, and that we need to, encourage a younger generation of leaders to, mentor them and help develop them to become engaged and be thinking about the future. So those are just a few random thoughts, but I wanted to just kind of try to initiate the discussion.
I can only speak to my own experience as it sort of in healthcare, specifically in refugee healthcare. But what I would say is that working in different refugee crises around the world, it became very clear to me very quickly that a lot of people find that work to be admirable, but the fact is that treating the medical sort of consequences of these crises is really like palliative. It's like treating the symptom of a disease, but it's really not at all addressing the underlying issue. Because if you look at the underlying issues causing these conflicts, they're very much either political or climate driven. And so I really had to change the way that I approached the whole situation, not see myself as a physician, but much more as an activist and a witness and an advocate. And that's very challenging, especially for physicians, because our profession has some of the worst political apathy of any profession, actually, in studies. And so motivating people to get more involved, like, a lot of people like hearing these talks and learning about these things, but how many people actually follow through and call their representatives or advocate for these things? That is really, I think, challenging. And that's why I admire the work of people like Rohini, who do zoom out and try to connect with legal advocates. And a lot of even in the Q&A, the questions are focused on legal issues, like things about the Constitution and the ICC. And so it's not enough to just be focusing on health or these little things. Like Dr. Levy was saying, it has to be interdisciplinary. So that's what I would say about that.
What are other, do the panelists have any of their own experience trying to connect in this space? I'll just speak as much to seed the conversation as anything else, that, we have many of our students are probably primarily motivated at this point in their lives on the climate issues, the typical climate health issues that are in their face. And it has been difficult. I'll reflect personally on being able to bring in the larger issues of militarism or nuclear weapons that PSR has been historically working on, and to be able to not make it an old issue of someone, when I grew up, that was very much on our mind, but to be able to connect in a very organic way what are these major existential issues that are illustrated through all of your talks and the impacts of all human beings. Have you encountered yourselves any challenges in being able to connect and being able to really be able to build the intersectionality that we need?
Sorry, Bob, I don't know if this answers your question, but I would say in terms of being able to connect, I think it's like crossing the lines from your group or your expertise into others, which, obviously is very, very uncomfortable. But for those of us who, on this panel, many of us have done that. And I think that's where the strength lies, is like frankly, like human rights is everyone's lane. Climate change is everyone's lane. And to like get yourself uncomfortable and, leave your box and sort of expand further. Like when I first met Sarah at the PSR, for instance, I was like, oh, she's a dermatologist. What's going on in Africa with dermatology? But the linkages that she brought, like those are so unique and open. And I think that's really important. Like we could all bring our expertise and cross it over to different places. And actually, while I'm answering that, I see Naomi asked a question about how much she's doing already and what else could I do. And, if someone had asked me this like 5 years ago, I would have probably said, wow, you're doing a lot, like good job. But I don't know, more and more, especially with having 4 children in my house, I just feel like this field is wide open. Like there's research to be done on every single aspect. There's advocacy to be done on every single aspect. Frankly, we could all just go vegetarian and that would help a lot. So I think there's a lot of like different ways, and then people need to engage in a way that like really leverages their expertise and their gifts. But I don't think like anything is enough really.
And I guess I just will add, I mean, speaking to your question and speaking to what Rohini just said, I think, and I mentioned this, I think a lot about my experience meeting farmers, which a lot of people in Western Kenya where I worked are farmers. And it was so interesting to see how climate change was so real to them. And they just kind of intuitively know that it's affecting their work already. And they're able to communicate about it without it being political or controversial. It's just, it is what it is. And the weather's changing and they can't grow crops the same way that they used to. And I think whatever we can do to amplify those stories is really helpful. And I also feel like pretty humbled by it. The economy there is so different. Like I mentioned, it's so much of the economy is based on agriculture. So many people rely on agriculture that the voice of the farmer is really important. And so whatever you can do to amplify that is absolutely essential when you're talking to people who are actually responsible for how the public health system is organized. So that's just one example that I think of among many.
I just really want to thank everybody here. I think you all just gave such extraordinary presentations. I just think this is really a wonderful session tonight that really provokes a lot of the questions that Rohini was raising towards the end, how we could best really deal with what often look like such insurmountable problems for us. And the best way we could start that is talking to each other across disciplines and working out the ways that we could best deal with the overwhelming challenges that we face. So thank you to everyone for being here tonight and our audience.